Just wanted to reach out to you all and just share with you a story that is not uncommon. And we can find these stories of our patients facing BPH BPO on Facebook. And here's one story from June 6th of this year. Hello, I was diagnosed with BPH about a year ago. My symptoms were frequently urinating throughout the night. I have not lost this much sleep ever in my life, and it is getting old. My doctor sent me to a urologist shortly after, and they were a horrible facility, and I never want to go back. Just herd me in and herd me out mentality. They tried to prescribe me Toviaz, but my insurance would not cover it. After a call to my primary care doc, they prescribed tadalafil and finasteride. Neither have worked, and I'm back at square one again, just up all night peeing. Side note, I've decreased caffeine, synthetic sugars, diet soda, etc. Just want this problem to go away, and at this point, I am just venting. Unfortunately, this is an all too common story that we hear, and I think we need to recognize that, yes, as defenders of the detrusor, we are here to preserve bladder health, to prevent late-stage BPH BPO, and put an end to the polypharmacy epidemic. We have to get ourselves out of this habit of reflexively, you've got a problem, take a drug. You still got a problem, take another drug. Still got a problem, take a higher dose. We need to all come together and recognize that medications, drugs for BPH BPO are temporizing measures. We are not anti-drug. Medications like antibiotics can be a solution to problems like sepsis. But for BPO, this is a mechanical problem that merits a mechanical solution when warranted. And in the case of BPH BPO, medications are temporizing measures that allow us to buy time to triage and obtain bladder health baselines. And so what I'd like to express is that if you are prescribing drugs, then please triage your patients. And you can do that through basic urodynamics. And you can see here in the red square here, basic urodynamics, like if they report a history of urge incontinence, retention, if their IPSS score is 8 and above alone, or in combination with a slow flow, less than 15 cc's per second, higher elevated residual greater than 100 cc's, or detrusor wall thickness of 2 millimeters or more, or unacceptable risk on bphtool.com, these guys need a bladder health baseline. You can see that on the right, where they have the bladder health baseline with a minimum of a cystoscopy. And remember, a combination of those basic urodynamic testing that we use for triage and a cystoscopy is the standard level of diagnostics. And when available, because it's not available all throughout the world, for example, you could go to multi-channel advanced urodynamics and really elevate it to the high level of diagnostics that we all aspire to. But more importantly is recognizing that drugs are temporizing measures and that we need to choose data over drugs. Drugs are temporizing. They help us get those bladder health baselines so we can deobstruct at the right time for the right prostate, for the right patient, with the right technology within the window of curability so that we can preserve bladder health and prevent late-stage BPH BPO. So I hope that helps a little bit, but I just want us to kind of realize that patients out there are struggling with BPH BPO, and we are contributing to the problem when we just keep prescribing without recognizing the need to triage for patients who need a bladder health baseline. All right, we'll see you guys on the next one. Take care. Bye.